Hi, everybody. It's Patricia Coughlin. I wanted to talk to you today about a couple of interlocking concepts. Maybe the umbrella would be, again, the importance of developing a clear case conceptualization to guide your interventions. There's a tendency these days to, I think, be very focused on technique. And when techniques are used either rigidly or willy nilly, just because you say, well, that's what we do in CBT or that's what we do in ISTDP, without being really conscious and intentional about how, why, when that particular intervention is called for in this particular case, you can really get some unintended consequences. And in particular, I'm an ISTDP therapist, and I think many of the people who are listening to this channel are as well. So I'm really going to be talking about the techniques of pressure and challenge, which are somewhat unique to ISTDP. And really, if you look back to Freud, to the development of psychoanalysis, right? He was quite an active therapist in his early days and would put pressure on patients, not just to face things and have insight, but to actually initiate behavior change. So this has a long history, right? We don't just sit there passively listening, saying, aha, and supporting whatever it is the patient is saying and doing, right? We're actually putting pressure on them to do something healthy, right? To face reality squarely, to face their own feelings, to take responsibility for themselves, not to wallow in a victim position. And then we challenge them to give up things that are hurting them, avoidance and self-attack and so on. And these are incredibly useful techniques. And they were developed by Davenlew specifically to address high resistance, particularly very rigid, intellectual, obsessive characters. This is the group that he was originally developing his standard technique to address. So these folks are cemented in rigid and syntonic character defenses, and so he really needed to up the challenge to create some anxiety, to get the conflict up and active. But what do you do when you have patients who are actually highly motivated? Their defenses and symptoms are already dystonic. And most importantly, these are people who are already very hard on themselves. They already pressure themselves constantly and demand, constant performance and perfection and so on. So if you end up putting a lot of pressure on these folks and challenging them when they're already doing that, and that in fact is at least partially responsible for their symptoms, their suffering, and their stuckness, right? How is that going to help? Right? So recently I've had 3 cases. I'm telling you, throughout my career, this has happened, right? I get these cases sort of in groups of 3 who will seem to highlight a particular issue or therapeutic dilemma or something that I have to learn from. And these 3 sort of fit that category, and they had all been in previous ISTDP therapies with therapists who were basically jumping all over them. They couldn't breathe, take a sigh, take a momentary look away, without the therapist pouncing on them. And again, since they already have that, hyper vigilant, critical, observer, really overly developed, it's not surprising that they got stuck and that these therapists ultimately did not help. It's not to say they didn't get any help, but they didn't really help them resolve their core difficulties. And so in these cases, I found that actually taking the pressure off and simply encouraging them was very, very effective. And it balanced out, right, their harshness. And it reminded me actually of the very first case in which this issue came to light. It was the detached observer. For those who have seen this case, he's the man in the wheelchair. And he had an extraordinarily, well, very disturbed, but extremely demanding critical mother who was never satisfied. I mean, this kid, was a straight A student. He was the captain of his football team, baseball team, basketball team, and was as good as gold. I mean, of course, never made a peep himself, always trying to be good and helpful, and yet she was constantly criticizing him. And so, it turns out he was extremely shut down, detached, and really actually fed the criteria for schizoid, actually. And so I did have to do a pretty heavy head-on collision with those defenses that were creating a resistance in the transference with me. And we got a massive breakthrough of rage and pain, toward me, linked to the mother. But that unleashed, of course, the unconscious therapeutic alliance. And this was early in my training, and I think I was, again, a bit overly zealous, and I kind of continued the pressure even after that. And he said, I don't need this. I mean, it's just like what my mother did. All I need is a word of encouragement. And in fact, it was true. So later on, when we were dealing with like positive, loving sexual feelings that were difficult for him to reveal, and he was kind of squirming around and wanting to avoid it. And all I had to do, he said, oh God, it's so hard. And I said, I know, but you can do it. And he did, right? So no need, right, to be bringing out the big guns and clubbing him over the head. So I think this is incredibly important, again, that you're being very specific. And this goes back to Alexander and French also. You don't want to repeat the same problems, right? That same troubled relationship they had with their parents, and that has been internalized. So if you have a patient who's extremely hard driving, demanding, critical, do not join them in that, right? And consider, obviously you can look at that and the negative consequences, but really focus more on encouraging them, right, to shift away from that, and that you, in a corrective way, are encouraging of them as well. And of course, you're often having to do both, right? Sort of challenge, say, boy, you've been doing this, nearly all your life. You don't need to do it here, right? Let's not make this process torturous, right? But can you support yourself to have a new and different experience, to understand yourself with compassion? So I really hope this is helpful, and that you'll think about not just doing a technique across the board without really taking the very specific needs and capacities of your patient into account. Okay? So I look forward to your questions and comments, and we'll continue our conversation. Thanks. Bye.